So my talk is about current concept of total elbow replacement. So there is I have no conflict related to this talk. There is a long history of total elbow arthroplasty, and it was not until D reported the use of a cement to fix a fully constrained hinge implant to bone that the modern age of replacement arthroplasty was born. So it was around 1970s. However, longer follow-up demonstrates high rate of failure due to loosening. A better understanding of elbow joint anatomy and biomechanics has resulted in improvement in prosthesis design and lead to two approaches. In the first approach, the joint were resurfaced with an unlinked implant with preservation of the collateral ligament for stability. Stresses across the elbow were absorbed in part by the soft tissues, resulting in less constraint at the bone cement interface with theoretically less risk of loosening. However, these implants were potentially unstable. These implants could be non-anatomic with a cylindrical humeral component rolling in the polyethylene of the ulnar component like the Kudo that you may know, or the IBP. But also they could be non-linked prostheses mimicking normal anatomy like the Ewald in the US, the Sutter implant in the UK and Europe, Sorby in Canada, or a Gepard total elbow arthroplasty in France, some with radial prostheses. All of these prostheses are mainly not manufactured anymore. The second approach to implant design was a linked prosthesis, which stability was provided through a linked articulation between the humeral and ulnar components. Modern semi-constrained implants have a slopy hinge that allows a few degrees of varus valgus and rotational laxity, decreasing stress at the bone cement interface. The potential weakness of this prosthesis was mechanical failure. The most popular linked implant were the Kunrar-Morey and the Discovery from the US, the GSB3, which was very popular in Europe, designed by Norbert Schwendt, is not anymore manufactured. The main complication of linked implant remain mechanical failure, especially polyethylene bushing wear, necessitating in some case bushing exchange, like you can see here. Another option is to move from an unlinked implant to a linked one with the same prosthesis and the same instrument with a convertible implant like the Latitude prosthesis to be able to choose a better option for the patient. From these experiences, the rationale of elbow implant design has been defined. The total elbow arthroplasty must restore function, be durable and doable. Functional range of motion between 30 and 130 must be recovered after total elbow arthroplasty. That imply ability to release soft tissue to gain extension while maintaining stability of the joint. Linked implants is to better achieve this goal, especially in very stiff elbow after a big release. Biomechanical studies have shown the high amount of forces at the elbow posteriorly directed that compromise stability of the first generation of anatomic implant. So stem implants have been designed and have shown to better resist to these forces. However, it was not sufficient, and with time, loosening of the stem implant occurred with anterior displacement of the humeral stem. Adding condylar support or an anterior flange has shown to limit this complication with time. Most of the design available nowadays have all this type of anterior flange. It is not still clear in literature if a radial head prosthesis must be used or not when doing a total elbow arthroplasty. Previous studies have shown fair results obtained with this configuration, like the Pritchard Walker or the Sorby implants. Theoretically, it can limit valgus forces, preserving the link system. However, this has not been demonstrated clinically. so far. Stability of the joint must be sometimes compromised in certain circumstances, where there is poor quality of the collateral ligaments, like in a rheumatoid arthritis, loss of bone or deformity. Link implants offer an immediate joint stability because of its intrinsic stability. The theoretical disadvantage was to increase stress at the joint linkage and at the bone cement interface. Little, in 2005, performed a comparative study evaluating 3 total abortoplasties, 2 unlinked, the suture and the kudo, and 1 linked, the Kunran-Moray arthroplasty, to treat rheumatoid arthritis, elbows. All 3 implants procedure relieve pain. Sustained improvement in the range of motion was comparable among the 3 groups. However, the 5-year survival of the Kunran-Moray implant was better than that of the other 2 implants. It seemed from this study that component linkage with a semi-constrained prosthesis like the Kunran-Moray implant prevents dislocation without increasing the risk of loosening, at least at 5 years follow-up. Same results have been observed and reported at Mayo Clinic after 25 years experience. The survival free of revision of all unlinked implant use at 10 years was 60%, whereas it was 85% for all linked implant use. This curve is especially impressive since 95% of the unlinked implantation were only for rheumatoid arthritis, but in the link group, 55% of the prosthesis was performed for trauma. Reviewing the Danish registry, the authors have shown better survival with link prosthesis, the line in blue on the table, versus unlinked in green, and with the Kunran-Moray prosthesis versus the GSB3, the Ewald prosthesis, and the suture arthroplasty. Again, in this Norwegian registry, better survival was obtained with linked implants like the GSB3 or the Discovery compared to unlinked implants like the Kudo or the IBP. In the same analysis, they found a lower survival rate with uncemented implants. Finally, published in GSES last year, coming from the New Zealand registry, this study have shown better result with the Kunran-Moray prosthesis compared to the convertible latitude prosthesis, with the number of revisions with the Kunran-Moray 72% lower than with the latitude. The Scottish registry has outlined recently the degrees of the number of total elbow arthroplasty related to a degrees in total elbow performed for inflammatory arthropathy like the rheumatoid arthritis, while total elbow arthroplasty for non-inflammatory causes increase over the same period. So the tendency is to indication for rheumatoid arthritis decrease, and indication for trauma or trauma sequelae seems to increase. Same tendency has been observed in different registry from Scandinavia. On your left is from Denmark, on your right is from Norwegian, and you can see these degrees of indication for rheumatoid arthritis. Here, another data from more international registry, like here, including the New Zealand data, and you can see again the degrees indication of inflammatory elbows with more trauma indication. If you want to summarize literature about the survival rate of the main total elbow arthroplasty used for rheumatoid arthritis, we can see that for the Kudo implant, the survival rate was around 85% at 10 years. However, you have to know that there were, during this period, there were 5 different types of Kudo prosthesis that have been used a long time. It was 75% at 10 years from the suture and 78% at 13 years for the GSB3. For the Kunran-Moray, the survival rate was 92% at 10 years and 68% at 20 years. I review my first 100 cases of Conrad-Murray prosthesis performed between 1997 and 2008 for various etiology. And where I found that the survival rate was 98% at 5 years and 92% at 10 years, confirming the result of Mayo Clinic. With a decreasing indication of total elbow arthroplasty and rheumatoid arthritis, trauma condition is becoming one of the main indications. For this etiology, a link implant is mainly used, like acute distal humeral fracture, distal humeral non-union, post-traumatic arthritis, and sometimes ankylosing or stiff elbow. The goal of a total elbow arthroplasty that can be discussed in acute distal humeral fracture in elderly patients is to obtain a pain-free, stable, and functional elbow. We reviewed during the symposium of the French Orthopaedic Society in 2012 the result of 87 patients of 79 years of average who have been treated with a total elbow arthroplasty for distal humeral fracture. The results were satisfactory on pain level, elbow stability, and function recovery. The Mayo elbow performance score was of 85 points with a quick dash score of 24 points. However, there were 20 complications and 8 revisions. The results of literature are similar with indication for patients around 80 years. In most series, a Mayo elbow performance score around 90 points, a functional arc of motion recovered in almost all cases, and a complication rate around 24%, with a revision rate of 11%. Only in series from Mayo Clinic, patients were younger because it concerned a mixed population with patients with rheumatoid arthritis and fractures. In the 2 series from Mayo with a longer follow-up, complication and revision rate were higher, with for the last series from 2016, 5, 10, and 50-year survival rate of 85%, 76%, and 76% for elbow with inflammatory arthritis, and 92%, and 81% for non-rheumatoid elbows. However, the use of Conrad-Murray in post-traumatic arthritis has shown the weakness and the limit of this kind of prosthesis, especially in high-demand patients with wear of the link system. They obtain in this series only 70% of survival rate at 15 years, and 75% of failure were observed in patients less than 60 years old. The treatment of excessive wear of the articulation is to remove and replace the articulation if possible. If the implant is loose, it must be removed and changed. However, in most of the cases, the implant exchange is usually not required, like on these cases, when the stem are well fixed. Here, 8 years after the initial procedure from distal humerus non-union. Same kind of result have been published in distal humeral non-union with a survival rate that decrease over time and we reach 65% at 10 years. It seems again in these populations that complication and revision increase with follow-up and was correlated with the number of previous surgery. 16% if there is no previous surgery and 33% if there were more than 2 previous surgeries. Here, clinical cases with this 70-year-old woman with this type of non-union. In 2014, we report our experience of total elbow arthroplasty in 2 groups of patients after previous ORIF for fractures, group 1 with post-traumatic arthritis and group 2 with non-union of the distal humerus. Patients were younger in group 1. At follow-up, better results were obtained in the non-union group with better DASH score and Mayo score. Furthermore, the complication was higher for patients with post-traumatic arthritis with a greater revision rate. In the non-union group, results were comparable to those obtained after total arthroplasty for acute fractures. Here, a personal example of post-traumatic arthritis treated with total arthroplasty with this 14 years results. The pre-cut ulnar component has to be revised at 14 years follow-up because of aseptic loosening without revising the humeral stem. Finally, total arthroplasty can be discussed in ankylosed or fused elbow if needed. In 2000, I reviewed Dr. Morris' patient. I reviewed 14 elbows that were evaluated at a mean follow-up of 5 years after surgery. As you see, the mean preoperative arc averaged only 7 degrees, and 9 of the 14 elbows were totally fused. The other 5 at less than 30 degrees of motion. Diagnosis was mainly post-traumatic arthritis. 8 out of 14 elbows had additional joint involved on the ipsilateral limb. After surgery, the mean arc of motion averaged 67 degrees. We emphasize in this series the development of ectopic bone around the joint, which was observed to adversely affect outcome. We also recorded 7 complications in 5 of the 14 elbows. This includes mainly infection. Overall, approximately 78% of patients were satisfied with the outcome. So total elbow replacement as a salvage for a dysfunctional ankylosed elbow or severe post-traumatic arthritis should be performed with caution. However, the outcome can be reliable, having a dramatically positive impact on patient function and satisfaction. However, with follow-up, the rather high complication rate reflects the limitation of this procedure. Especially the mechanical complication indicates that in younger patients, total elbow replacement may only be performed with reservation and only for those who do not perform strenuous physical activities. The future of the prosthesis will rise from the experiment of the past and the possible correction of the weakness of the current implant. We see right now an increased proposal of implant for degenerative lesion of the elbow, hemiarthroplasty, for limited lesion, especially distal humeral fracture, unicompartmental arthroplasty, and convertible arthroplasty. System for revision could be developed with different stem options, cemented or not cemented, with modularity to deal with different cases of bone deficiency. Accurate replication of flexion axis seems of paramount importance to reach the normal kinematic of the elbow and to increase the longevity of this implant. This can be still improved with development of reliable landmarks, anatomic stent shape, improved instrument, or maybe compute-assist surgery. However, there is still a particular weakness of the linked implants is the link system. Different experimentals have been done to minimize link failure with follow-up. In the discovery design, there is a more constrained axle mechanism than the Crouan-Moray prosthesis with a bigger system and a thickest polyethylene. In the latitude system, the design of the humeral component allows to maintain maximum contact with the ulnar component throughout 7 degrees of various valgus laxity of the articulation. The polyethylene of the ulnar component is thickest anteriorly in the rear of the maximum loading. The Nexel elbow system evolution of the Crouan-Moray offers thicker polyethylene bushings and stronger link system. The polyethylene characteristic can be also improved, and alternative bearing surface can be maybe found and tested. Decreasing the rate of loosening remains also one of the most important problems with total arthroplasty. It can be performed by improvement of cement technique as well as improved stem design and treatment surface. The use of uncement stem could be a solution, an unfavorable bone, but must be proved clinically. Triceps weakness is another problem related mainly to the surgical technique and can be improved. The triceps on technique has been used now to preserve the triceps, mainly in trauma cases. Finally, the infection rate remains the highest after joint arthroplasty compared to other arthroplasty. Many factors could participate to decrease the rate of infection, like the surgical time, adapted antibiotic prophylaxis, and better patient selection. To summarize what I've learned so far, the ideal total elbow arthroplasty must be stem, must be flange, should be linked, must have surface right, must minimize wear, must be flexible, should be easy, and must be cemented, even if uncemented prosthesis could also be another option. Total elbow arthroplasty is now being used to successfully treat elbow conditions that have traditionally been treated less successfully with other methods. However, the complication rate may be high, so careful selection of the patient, preoperative planning, and the experience of the surgeon are prerequisite for success. The future could be a compromise of what have been used so far with some new ideas that has been to be validated by experimental and by clinical data. Thank you for your attention.